and thank Dr. Hari for all the efforts which he has put in to make this such an excellent event. So without wasting much time, I will start off my topic, which is Post Covid Airway Complications. So in India, we are very happy that we have actually finally conquered COVID. But then why is it important? Because it's always important for us to look back, learn from what all has happened, so that in case we have another wave, we can deal it much better. So when we talk about COVID airway complications, you can broadly talk about two groups of diseases: post-COVID central airway obstructions and also post-COVID peripheral airway involvement, which is also very important. So when we talk about central airway lesions, if you look up the literature also, the two most common things which come up are the post-intubation and the post-tracheostomy stenosis, which have been dealt in the previous talks also, and you have some uncommon lesions which are there. Now, Indians are very popular for giving fancy names. So we have given a name, quotes. This is by Dr. Karan, who was there in the morning. So COVID-associated tracheal stenosis. So the three questions which we have to understand when we talk about COVID-associated PITS or PTTS is PITS or post-tracheostomy stenosis more common after ventilating for COVID ARDS? Second, is it more severe than the common garden variety PITS? And three, does it have to be managed in a different way? So the first question, is it more common to have PITS after ventilating for COVID? There are a lot of literature, a lot of case series, but the answer is probably yes. So in fact, this has been described as a parallel epidemic. We have certain studies which have shown that there is a higher incidence of post-intubation tracheal stenosis following ventilation for COVID ARDS. Also, there are several reasons which have been postulated. In fact, at our center also in the last year, that is following the second wave of COVID, we have had an epidemic of tracheal stenosis. If you could look at the images, you have complete cutoffs, you have web-like stenosis, you have pseudocrotic stenosis, almost every sort of tracheal stenosis we have encountered in the last 1 year. And there are certain studies, papers, which have compared COVID ARDS versus non-COVID ARDS, and what they have shown is that the incidence of full thickness tracheal lesions or post-intubation tracheal stenosis is commoner after ventilating for COVID ARDS. Why is it so? Again, there are several reasons which have been postulated. I would say these are all postulations, they're not proven. Some of the postulations are that probably there is a higher rate of intubation trauma. This is because of the PPE care, this is because of the physician burnout, longer durations of mechanical ventilation, longer needs of prone ventilation, which might have probably affected the cuff pressures, and also lesser monitoring of the cuff pressure in the ICUs, which are already facing a staff crunch. Then, is there a direct effect of COVID on the tracheal mucosa? Probably also yes. So I'll show some of the papers which have looked at it, and also the COVID-associated prothrombotic state also is said to cause microvascular injury of the tracheal mucosa and lead to tracheal stenosis later on. These are all possible reasons. So some of the evidence to say that COVID directly can cause tracheal stenosis, these are two case reports. One is from Dr. Karan, which is on the right side, and the one is from outside. So both of them were not intubated but yet developed tracheal stenosis. So this is also meaning that COVID directly can lead to tracheal inflammation, tracheitis and tracheal stenosis. This is one of our cases where following COVID, after intubation, she developed left main bronchostenosis. There was no manipulation of the left main bronchus. This was managed again bronchoscopically. Also, you have several case series where they've looked at the resected tracheal specimen, and they have shown that there is viral cytopathic changes and there is microvascular injury and vasculitis in the resected trachea. All of these point towards the fact that COVID directly may be contributing to some of the tracheal stenosis which we are seeing. Now, the second question is the so-called COVID PITS or COVID PTTS more severe than the normal PITS or PTTS? You don't have any data comparing, but in our experience, what we have seen is that most of the post-COVID PITS or PTTS were complex, they were not simple, and we have seen a lot of complete cutoffs of trachea following tracheostomy. This is probably, we've seen the highest number of complete tracheal stenosis in the last 1 year following this COVID tracheostomies. The last question, do they have to be managed any differently than the PITS or PTTS? The answer is no. The same principles which were discussed earlier would hold true for even post-COVID PITS or PTTS. If the person is not symptomatic, you just wait and watch. If it's a simple stenosis, you can do dilatation. If it's a complex, ideally surgery. If surgery is not possible, then you can manage with some sort of a tracheal stent. 2 case vignettes, only images. This is a short segment stenosis which was managed only with electrocautery incisions, balloon, and then you have a good lumen. Another case, this is a complex stenosis where you had a subglottic tracheal polyp, and then beyond the polyp you had a complete tracheal cutoff, tracheal granulation. So this was discussed in our group discussion also, and the patient refused to have a surgery. So this was managed with dilatation, polyp removal, and placement of a silicone stent. So there are so many cases, but then for the sake of time, we'll just go through the remaining presentation. Now, beyond PITS and PTTS, which is most often talked about, so what other things can COVID cause? There is a lot more. Tracheoesophageal fistulae have been described. Some uncommon things, swab stick aspiration. This is from Dr. Vishwanath's team from AG Hyderabad. Some nuts wanted to do a swabbing through the tracheostomy, and the tracheostomy, the swab stick broke and it went into the bronchi. If you look at the literature, there are 2 to 3 more cases where the tracheostomy swab stick actually got aspirated into the right main bronchus and it became a foreign body. Then you also have nosocomial infections. India had seen a very bad post-COVID mucormycosis, COVID-associated pulmonary aspergillosis. A subset of them can also have tracheobronchitis. So this is another way COVID can affect the central airways. These images again are courtesy Dr. Vishwanath. This is a person who expired, and this is a bronchoscopy done post-death. So if you can see, the whole trachea is flooded with this proliferating fungi. This was aspergillosis. So this is one of the bad complications of steroid use probably, and probably some effect of the COVID per se. Now talking about the second part, which is COVID peripheral airways. We all talk about central airways, but COVID also affects the peripheral airways, the small airway dysfunction. This is a very significant number. Persistent post-COVID respiratory symptoms, we all have managed COVID. We all know that after recovery, almost 40 to 50% of people who recover do have cough and dyspnea. And small airway dysfunction is one of the reasons why they have persistent breathlessness and cough. Do we have evidence? Yes, this is a prospective cohort study from, I think, Italy, which has said that up to 80% of people following COVID recovery, they have breathlessness. And if you do impulse oscillometry, which looks at the small airway function, up to 88% of them had abnormalities in small airway function. And on follow-up, also 70% at the end of 5 months, a repeat impulse oscillometry was done and they still had small airway dysfunction. So COVID impacts the small airways also. Then this is another Brazilian long-term cohort study, 1 year follow-up of patients. Again, what they have shown is that small airway dysfunction was there in 30% of them following recovery for COVID. Indian data, again from the team AAG, they have looked at, this is a study of 2,400 online surveys. Up to 30% of them had cough and breathlessness. Again, probably a subset of them is because of small airway dysfunction. So small airway, peripheral airway disease also a significant cause of respiratory symptoms. Our observations, again, most of these COVID survivors, they had residual symptoms, more common in sicker people as compared to stable people. But other than this, the second thing which we observed was the so-called hyperreactive airways. Most people who recovered from COVID, especially after the Omicron, also had hyperreactive airways. They had wheezing, cough, behaved similar to asthma, more common in atopic individuals, responded well to bronchodilators and ICS. So this is the third part of this thing. So development of an asthma-like syndrome. Look again, if you look into the literature, the similar experience has been there in other countries also. Similar experience of developing asthma-like syndrome following mild or moderate COVID infection, and which does respond well to bronchodilators. So with this brief talk, I would want to summarize that COVID can affect both the large airways as well as the small airways. Central airway obstruction is definitely not as common, it is less common, occurs only in people who are on ventilator, but this can be life-threatening and this is a preventable cause. COVID-associated small airway diseases affect a much larger proportion of people. They cause more morbidity but not mortality. They occur independent of the disease severity of COVID, and this may not always be preventable. I think with this, I will end my talk on post-COVID airway complications. Thank you so much.